Hello, good morning, everyone. I'm Philip James, and today's guest is Dr. Ralph Tufano. Dr. Tufano, welcome.
Good morning, Philip. Thank you for having me.
So today's topic is spend $5,000 out of pocket for RFA or potentially zero out of pocket and let your insurance pay for a thyroidectomy and lose your thyroid. Before we get started with today's topic, there have been some exciting developments for you and some changes professionally. If you could please share with us what's going on in your life.
Well, after more than 20 years at Johns Hopkins Hospital and medical institutions and having a wonderful career there, I've decided to move down to Sarasota, Florida, and join the Sarasota Memorial Healthcare System. They provided a number of resources to develop an integrated, truly multidisciplinary thyroid and parathyroid center where we could put the patient at the center of the care episode. And so being able to have an endocrinologist and have a team of doctors giving a multidisciplinary, interdisciplinary approach to help the patient decide on what the best treatment is, the resources there to support the center and allow the patient to be at the center of all of the decision making is fantastic. So I've always endeavored to do this, always dreamed of doing this, and now we're going to have the opportunity down here.
Well, congratulations. That's very exciting news. And for those listening who want to get in touch with you in Florida, your contact information will be listed in the description to this episode. You really advocate for patients to be as well informed as possible and consider all treatment options for thyroid problems, including avoiding surgery whenever possible. And it almost sounds contradictory because here you are a surgeon, and in some cases, you are advocating for patients not to have surgery. Can you please tell us more about this perspective as a surgeon treating thyroid problems?
Yeah, I think it's important to make sure that the patient understands all of their options available for treatment. And so working as a team with other providers, such as endocrinologists, it helps you to have a more unified approach as to consider all of the options regarding management. If you just came to a surgeon, for example, you may have only that surgical perspective, and you may be more apt to undergo a surgical procedure when you may not really need that surgical procedure, or you're more apt to undergo more surgery than you really need, or sometimes actually not enough surgery. So working as a team to develop that plan and having the medical side considered and our endocrinology colleagues involved, working with the pathologist to understand the disease process, that helps us to fine tune and personalize the care for the patient and provide them with all options available for treatment so that they can make the value-based decision that they feel is best for them. That's really important. You know, Philip, sometimes a patient will present with a disease process and it hits us right over the head. Everybody can agree that that is the best treatment of choice. The evidence is irrefutable. But a lot of the times when we're dealing with thyroid disease, thyroid nodules, thyroid cancer, there are many options available. We can't be paternalistic. We have to disclose all of those options, even if we don't perform them, and allow the patient to make that informed decision. The patient has to take the reins in this process. They can't abdicate to the healthcare providers or anybody else about their care. They have to say, look, I understand my options. I'm going to get as much information as I need, whether it's other opinions, other consults, reading, talking to family members, so that they can make the informed decision and decide what's best for them in those situations. That's really important to support. And I feel that, that is what I enjoy doing, is being able to help my patients in this process. The easier part is to do the actual procedures or interventions.
So it really is all about the patient being well informed and being able to make the best decision possible. Which brings us to the question for today's interview, which is $5,000 out of pocket and save your thyroid, or thyroidectomy and maybe nothing out of pocket with an insurance paid thyroidectomy. What do you think of that idea?
Yeah, well, Philip, I would ask you, you underwent a thyroidectomy, and you can describe to us a little bit about your course. But again, my point is that if there are options available, if there is an option available to avoid surgery, and it gives you an equivalent outcome or maybe even better outcome, why wouldn't you choose it? And obviously, the finances come into play, and we are certainly very, very, understanding of that, and we want the patient to make the decision. They can't make the decision unless they're informed about all of these options. So it's not for me to judge that, oh, well, maybe this patient is not going to be interested because it's $5,000. I will still explain that option for treatment and allow the patient to determine if that's going to be best in their circumstance. So for you, I would say, would you spend $5,000 knowing what you know now?
Yeah, so the real cost of thyroid surgery. And I look back and boy, I wish I could have had this conversation before a thyroidectomy and knowing you before a thyroidectomy, because it's true, not all surgeons have or present the information that you present. And often we hear it from other patients too, that they're told, yeah, once you take your thyroid out, you're just going to take a little pill every morning and life is good. But I think we have to, and I can talk from personal experience, I think consider two additional costs that happen after thyroidectomy. One is the potential for error. Two, the long-term life-changing cost. And there's been a couple interviews on the Dr. Thyroid podcast that talk about, and it sounds really kind of far out there, but one is out of Rush University where they talk about thyroid cancer, thyroidectomy patients having a higher incidence of bankruptcy and job loss. And then the other research is out of University of Michigan and how it affects after thyroidectomy quality of life. So maybe you can elaborate a little bit on one, the first cost, the dangers of doing a thyroidectomy, and then two, if we could kind of discuss the long-term life-changing cost of a thyroidectomy.
Well, Philip, you hit the nail on the head. I mean, I think no matter how experienced the surgeon is, there's always a chance that during a surgery for removing the thyroid or a portion of the thyroid, that there can be a complication. Everything from the general anesthesia to the wound healing, in fact. So if there's an opportunity to avoid that, then I think we should pursue that. We should investigate it or see if it's an option. And then what the other thing is that as surgeons or as physicians, unless we've gone through the experience, we can't say what it is to live without a thyroid, to be on thyroid hormone, to possibly have hoarseness, to have that impact your quality of life, or needing to take calcium every day. So it's paternalistic of us to say, oh, don't worry, we just take it out and you take some thyroid hormone and you'll be fine. And so in that circumstance, we have to be open-minded. We cannot be paternalistic. We have to provide all of those options and let the patients make that decision. Hey, what do I think is going to be best for me? Because I haven't lived through that. And no matter how many I've done of these surgeries, I know that there's always risk. I never take it for granted. And I also don't know exactly how that patient will do after I'm done with my intervention. So I always make sure that I'm not so casual or matter of fact about just take it out and you'll be fine. I never say that to a patient.
Dr. Tufano, it's so refreshing to hear your humility as a surgeon, somebody who has your kind of recognition and respect in healthcare, to say that, in fact, no matter how good a surgeon is, sometimes errors can occur. In really going back to your podcast, where you are such a proponent of doing everything possible to avoid a thyroidectomy, which
Right.
says you kind of surrender. If someone were to say, as a surgeon, they always want to do surgery because it's in their kind of self-interest. You're saying, no, self-interest is aside. We need to do what's right for the patient.
Right. I only want to do surgery when there's value, when I know the patient will realize a difference in their quality of life and their overall outcome that it's going to be decidedly better to do the surgery than to leave them without surgery. And that's why working with a team of other doctors, including the patient and psychosocial support, the family involved in the decision making, is so important, so you don't get such a biased or skewed decision making process, right? Because if all you go to is a surgeon, well, sometimes that's all the surgeon knows, and it may be just doing surgery or doing a lot more surgery than you really even need, or not enough surgery. So these decisions need to be made as much as possible with a lot of prudence and a lot of involvement of all of the specialists involved in the care for a patient who has that disease process, making sure that they're all on the same page, and then ultimately the patient saying, yes, this is the best thing for me, and I'm going to go forward without any reservations because I've been involved in this decision-making process and I'm taking control of my healthcare.
With what you just said, you just raised the bar really high for all surgeons around the world as far as the way you build your team. Because if I heard you right, you said you even have a psychologist on your team.
Well, we have everybody involved, and whoever we need to help make that decision for the patient, we are really interested in providing them with support in making that decision. So yes, we have that capability to help and assist them in making the decision if need be.
And to backpedal, so a patient gets told they have thyroid cancer and it can feel quite devastating. Now, we're talking about RFA, so maybe they're told they have a thyroid nodule that's causing them problems, or it could be cancer. And that is a very stressful moment for any patient. And it does take hours or days sometimes to kind of process it. It's great to have the emotional support.
It is incredibly important. And even as a physician, what I want to tell the patient is, please, this diagnosis that we're giving you right now, we're going to try to provide some supportive information, but it may take a little time to sink in. What the worst thing that can happen is you take that information and you act on it impulsively to try to get something done as soon as possible because you're afraid about, God forbid, a cancer diagnosis, and my gosh, why don't they just take it out today? Or they're gonna wait. I'll go somewhere where I can get it out today. And that is a problem because then you may have more problems to deal with lifelong. You think about it, you try to get all of the support to help you make the decision, talk to the right people, and then you will be able to do what's best for you, make that decision that's best for you. And that's important for us. I always tell the patient, look, there are conditions where you need immediate treatment, but this is not one of them. Sit down, think about it, talk with your loved ones, talk with other specialists, get other opinions, and then after that, make the decision that's best for you. That's important.
So with RFA now, it's exciting because for thyroid nodules, they can be removed without doing surgery. Is this real?
So it is real, and we're not removing the thyroid nodule. So in the circumstance of, let's say you have a big, large nodule in your thyroid, it's kind of like a goiter, an enlargement of the thyroid, and that nodule bothers you. First of all, everybody tells you about it, including your grandmother. Hey, what is that thing in your neck? What are you going to do about it? And then it bothers you when you swallow, or positionally, it maybe makes you feel uncomfortable if you're lying on one side, or your breathing maybe a little bit difficult. And, before RFA, all you had was surgery, really. And obviously with surgery, we talked about the possible risks of surgery. And of course, probably more concerning sometimes to a lot of people is if you take out half of the thyroid, even if you're functioning normally with your thyroid levels, you're having normal thyroid function, 25% of those patients will still need thyroid hormone. So people are afraid of taking thyroid hormone, especially if you're feeling quite well otherwise. Why should you take out a normally functioning gland? The beauty of RFA is that, first of all, in most circumstances, it's no general anesthesia. You can do it in the office, much like when you go to your dentist and maybe you're getting a cavity filled, you get Novocaine or lidocaine to numb up the neck area. And then under guidance with an ultrasound, you take a needle you can heat at the end, and actually cook the inside of the nodule so that it involutes and starts to shrink over time. The body does this in the healing process. And the beauty of that is that the overwhelming majority of times, it does not change your thyroid function. So think about it. We're talking about an invasive procedure, surgery, general anesthesia, complication risk that is significant, if not done, especially in very experienced hands, but even in experienced hands, there could be a possible complication. And we're talking about needing possibly thyroid hormone in a patient that otherwise has normal function of the thyroid, to a situation where you're going to an office, getting some lidocaine, having a 30 to 40 minute procedure, going home 20 minutes later, and really having very little chance of needing any thyroid hormone or having any change in your thyroid function. That's a big game changer. And I think that this is really unique. It's very disruptive to our field, in fact, because we've been talking about doing other types of surgery, and I enjoy doing a scarless surgery to avoid a scar in the neck by going underneath the lower lip, transoral surgery. But that's just another way of doing surgery. This is completely disruptive and game changing. It's a completely other way to treat the thyroid. So very exciting.
When you share this news with a patient or this alternative, has a patient reacted and said, but it's $5,000 and my insurance will pay for a thyroidectomy?
Yeah, this is real world. And some people do not have the means to pay for radiofrequency ablation. And as you mentioned, right now, it's mostly an out-of-pocket cost. There's very few, if any, insurance carriers that are covering it. So that definitely, is in the mix as to how they make a decision. And we're cognizant of that. We're definitely understanding of that. But we still produce RFA as an option if they are a candidate for radiofrequency ablation. It's a tough call. It's a really tough call for some of those patients. Sometimes you're right. They may say, look, I wish I could do this, but this bothers me enough that even if I don't have the money right now, but it bothers me enough now that I still want surgery. So thank you for explaining this. This sounds great. I would love to do it. I just can't. But they had that option. They were given a chance to make an informed decision. That's the most important thing, I think.
And it's too early to know if that patient that chooses surgery is going to regret having the surgery and not figuring a way out to spend the $5,000.
Right. No, I would agree. And that's why in the decision-making process, it's very important that you are supportive of the patient in all aspects, and that when they come to a decision as to how they're going to proceed, you be incredibly supportive of that.
So let's pretend you're in your new neighborhood in Florida, and one of your neighbors approaches you and says, Dr. Tufano, I'm going in for a thyroidectomy, and my insurance is going to pay for the whole thing, whereas I'm avoiding paying $5,000 out of pocket and having RFA. What would you tell him or her?
Well, I think in the decision-making process, if you have this thyroid nodule that's really bothering you, and you're bothered by the way it looks or the way it feels or how it interferes with your swallowing or your breathing, then I think you need to do something about it. If it's going to be on your mind, then it impacts your quality of life. I would say to them that if there's a way to figure out how to avoid surgery, it's probably in their best interest. First of all, if you do radiofrequency ablation, and even if it were to be unsuccessful, which for the most part, it's probably unlikely that it would be unsuccessful, given that you're treating a benign nodule and you're trying to shrink it. So we endeavor to get a 78 to 80% reduction by about 6 months. We don't necessarily have to get rid of the entire large nodule. And patients start to feel symptomatically better within the first month. It's amazing how sometimes the symptom improvement really comes before any dramatic reduction in size. But I would say to them, if they could avoid having the surgery and going through radiofrequency ablation, with surgery always being an option later on down the line if need be, but unlikely to be needed, then that would be the best way to go, because you're not taking out normal thyroid tissue. And the thyroid is functioning normally. It's unlikely that you'll need any change, or you have any change in your thyroid function. It's unlikely you'll need any thyroid hormone. Just imagine if you have your surgery done, and even if you take out one side of the thyroid, a lobectomy, you're taking out normal thyroid tissue, normally, thyroid tissue that's functioning normally. And so you may still need thyroid hormone. Now think about doing that every day for the rest of your life. That's a big, disruption in your life. And you don't even know how that's going to impact your overall well-being and how you're feeling. Because some people, like we were talking about before, we say, oh, just take it out, you'll take some medicine and you'll be fine. We don't know that. So for me, it seems like the best first step in trying to treat this with the least amount of downside.
Hopefully, for those listening, and they have a thyroid problem, a goiter, or a nodule that can be treated by RFA, that they seriously consider RFA in preserving the thyroid as a treatment option versus a surgery or thyroidectomy. Now, can RFA be used to treat malignant thyroid nodules or even indeterminate thyroid nodules?
So, Philip, I truly think that over time, this technology will evolve. It'll become more exact, it will become more automated, and I think we'll be able to treat these other conditions like you just mentioned, cytologically indeterminate nodules that on fine needle aspiration biopsy, we can't tell if it's a cancer or not, even with molecular testing. And even some small differentiated thyroid cancers, especially if they're located in a favorable position. So I think that we are starting to use this technology for papillary microcancers, those microcancers that otherwise would be considered for active surveillance or just watching it. A lot of people don't feel comfortable with watching a small cancer, no matter what we tell them. And that should be understood and supported by the caretakers, the physicians. Another option, as opposed to surgery, would be to do radiofrequency ablation and try to treat that nodule and ablate that nodule. And some colleagues in China have done some very good work in this area and have demonstrated that RFA is very effective and more effective than surgery, in fact, in ablating and controlling papillary microcancer without any real complications. So I think that that will come about, and also treating nodal metastases for differentiated thyroid cancer. In patients who have undergone multiple treatments, multiple surgeries, they may not want to go through anything more. Any more surgery would be very dangerous, for example. And so those patients that were getting ethanol injections, the RFA seems to be a little more focused and maybe a little bit more able to control that destructive process in that area, so you can protect those important structures that you're trying to keep working. Ethanol is a little bit more toxic to nerves, as we know, and causes a little more fibrosis. So RFA may have a little bit of an advantage in that area as well. So it's a very exciting time to think about these new technologies, these new treatments. And I certainly think that together with imaging that will evolve and automation and being more precise in being able to deliver the energy, we're going to be able to see increased utility, more options for treatment, more cases where we're going to be able to use it in.
So let's have a little fun. If there was a billboard displayed about RFA, what would the billboard say?
Oh boy, it's on a billboard now. I think it should say radiofrequency ablation, RFA, for thyroid nodules. Is this right for you? Consider it as an alternative to surgery in the appropriate circumstances. And I would say call this number to find out if you're a candidate or if you're eligible for an RFA treatment for your thyroid disease process. I would never have that billboard say, get RFA now, call right here. All comers, and we'll take everybody. Again, we have to be very thoughtful about who is undergoing RFA, make sure that we support them in the decision-making process, and that they have realistic expectations as to what their outcomes will be and what they will experience. And then if it's right for the patient, then we are completely supportive and happy to help them in the process.
If a patient is looking for an RFA doctor, where would you send them? Are there resources where they can find a list of RFA doctors?
So this is critically important because people want to know, where do I get that information and good information? And so rfamd.com would be a great resource for them. They can go to that website and they'll be able to find a doctor in and around their region or anywhere throughout the United States, or maybe will be included people in other parts of the world as well, for them to get their RFA, or at least to be considered for RFA. So great resource, rfamd.com.
Dr. Tufano, this has been great. Thank you so much for being here. Before we say farewell, are there any final thoughts that you would like to share with those either watching this interview or listening to it?
I just want everybody to understand that the care process is centered around the patient. It's always about doing what's best for the patient, helping them to come to the decision, helping them through the decision-making process all the time so that they can make the best decision for themselves. And each and every patient is different. And for us to appreciate those differences and be supportive. That's why we do this. It's for the patients. And otherwise, that's my motivation every single day, to be as good as possible to help my patients make the decisions that are best for them and their families so that they can live a healthy and wonderful life, hopefully, as best as they can.